palliative care is not only about the end of life, it's also about how we prepare for the end of life and how we plan. And our next presentation is going to be on that subject, on advanced care planning. And we're going to hear from two members of our palliative care team at the University Health Network, Dr. Ahmed Al Awamer, who has been the lead on this conference. He's a palliative care physician at the Princess Margaret Cancer Centre, and he's taken a great interest in this issue as well as in many aspects of palliative care. And Dr. Ebru is a palliative care physician. She's the lead of the UHN palliative care team at Toronto General, Toronto Western Hospitals, and a very experienced palliative care physician who's also been involved in this issue of advanced care planning. So, Ahmed and Ebru.
Hi, everyone. So, our talk is going to be split into two parts. Sorry, I forgot the non-disclosure slides. Neither of us have anything to disclose, any conflicts of interest. So I'm going to present the first part, and then I'll have Ahmed take over and present the second part. So my first part is going to be more of a kind of generic talk on advanced care planning, and then Ahmed's will be a little bit, hopefully a bit more specific to the religious aspect. And I'm hoping that I can talk about, what healthcare consent and advanced care planning means to be in particular in our province, in our own province in Ontario. And then have us be able to list the reasons why it's so important to do advanced care planning. So what I think is really interesting is to note that, there's a recent poll in 2012 that looked at what we think as Canadians about the issues around advanced care planning. And it was really interesting to know that 86% of us have never even heard of advanced care planning or what that means. And what's not surprising is that 60% of people don't want their families to be burdened with these difficult decisions that have to be made at the end of life. And that even though they don't want their family members to be burdened, less than 50% have actually discussed their wishes with their families. And even more appallingly, 9% have ever talked to a healthcare practitioner about their wishes. And even those patients with advanced cancer, even they haven't had, only 37% of those patients have had the opportunity to discuss end-of-life care with their doctors. So we've got a lot to do, but what does advanced care planning actually mean? And I know that there are lots of terms and words that are branded about that we use. And, like advanced directives, like living wills, like DNR orders, is that what advanced care planning is? Is that what it means? I'm hoping that I'm going to be able to talk about some of these terms and how they apply and how it's not appropriate to use them within our province. So if you look at any of the major groups or organisations involved with advanced care planning in Canada, such as the advancedcareplanning.ca website, or go on the Canadian Hospice and Palliative Care Association website, or any other kind of organisation, it's defined as a process of reflection and communication. And I'm going to explain a bit more about what I mean. So by reflection, what I mean is that the idea is that as people, individual people, and either a current, past, or future patient, we think about what our values are as individuals and what's important to us and what gives our life meaning. And that what does quality of life mean to us in the context of healthcare? And if we have an illness and think about getting sicker or weaker with time, is there anything in particular that makes us worried about this? And when we think about life-sustaining treatments, is there anything about those treatments that makes them unacceptable to us as individuals? And there are, of course, a lot more questions. I just put up the ones that, I thought were helpful and a priority when I go and talk to my patients. And after we've done that reflection, the other piece of that, of course, is the communication piece. We need to do something about that. And that means talking to people that are important in our lives, our family, our friends, but especially our substitute decision maker, and our healthcare practitioners, our healthcare providers, and communicate those wishes to them so they know what's important to us and our value system. And it doesn't have to be in a written form. It can be in any form that we want it to be in. And again, to reflect our individual wishes and desires and who we are as individuals. Why is it even important? Well, sometimes I know we worry that when we talk about things that are sad, that we're going to potentially take away what little hope a patient has, make them depressed, and maybe speed up their dying process. But if we look at the literature, actually talking about these issues has the opposite effect. We know that patients and family satisfaction improves when we talk about end-of-life care issues openly and honestly. And it doesn't take not much of a stretch to think that talking about this stuff would make it more likely that we would end up being in our preferred place of death. And at the same time, how I mentioned that we don't want to burden our families with making these difficult decisions. We know that we can reduce some of that caregiver distress if we do talk about these decisions before a patient becomes incapable. It does reduce their distress and their trauma. And at the same time, there's evidence that it can reduce hospitalizations and admissions to ICU, and of course, associated with that, reduce healthcare costs overall. So win-win for us and win-win for our healthcare system and our society. So just a question, I thought, just to get us in the mood and to think about it. Does everybody know if you can have an advanced care planning discussion with the substitute decision maker of an incapable person? You don't have to shout out the answer, but just think, what would be your answer? I don't think all of us know that substitute decision makers actually can't do advanced care planning for another person. Substitute decision makers really can only either give or refuse consent for a particular treatment on the behalf of an incapable patient. Really, only we can do our advanced care planning for us if we're capable, when we're capable. What about documenting those wishes that I talked about? What if we documented them in an advance directive or a living will? Is that something that we can do? Well, it's really interesting that in Ontario, advance directives, living wills are not really in our law, in the Health Consent and Capacity Act. And so it's really, really important for us to be aware of that because, these terms might be perfectly within the law in a different province or outside of Canada, but it's not something that applies to us here in Ontario. And it's really, really important to remember that. And, I work with colleagues who have come from other parts of Canada. I myself went to medical school outside of Canada, and I work with, look after patients and families who have moved across Canada or who have relatives who have come across from the States. And so it's really important for us to know what the legalities are within our own province that we work in. And not forget that, the law varies from province to province within Canada. It's really, really important. And the only parts of the advanced care planning that needs to be done in writing is when a patient wants to name a person other than the automatic substitute decision maker that's assigned to them in the law. And they can do that by preparing what's called a power of attorney for personal care document. Okay, the advanced care planning is about communicating our wishes, our values and beliefs, but this is to guide our substitute decision makers. Okay, and that can be done, it doesn't have to be in writing at all. And again, just to belabor that point, in the law here in Ontario, advanced care planning is not the same as obtaining consent for treatment. It's really, really important to remember that. Okay? So we always have to make sure that we're getting informed consent or refusal for a treatment, either from a patient that's capable or their substitute decision maker, regardless of what wishes have been recorded in their records. And again, just to remind ourselves that consent comes from a capable person. It doesn't come from a document or, an advanced care planning form. And that consent is required for all treatments. And it's based on the patient's current health condition. Right? And that, not to forget that informed consent involves talking honestly about any potential risks or benefits of the treatment that you're offering, any side effects, and what would happen if they refuse that treatment, and are there any other alternatives? Only then can it be informed. And just again as a reminder, this is the hierarchy within our law in Ontario for a substitute decision maker. So if I give you an example, if for instance there was a woman who did not want her husband to be her substitute decision maker, and legally it would be her husband, she wanted to name, for example, her eldest daughter, then she would have to prepare a written power of attorney for personal care document in order to name her eldest daughter to be her substitute decision maker instead of her husband. Okay, is that clear? So I'm going to lead on to part 2 now.
Okay, good morning, everyone. So as you can hear from the first part, the importance of advanced care planning in palliative and end-of-life care. Now, in my part, I'm going to talk about some of the struggles and barriers that may affect the completion of advanced care planning, and I'm going to reflect on my experience with trying to help some of my Muslim patients trying to complete advanced care planning. So we know from the existing evidence and research that there are many barriers exist to advanced care planning. Some of them are provider-related, institution-related. I'm going to focus today mainly about patients, ethnic minorities, and Muslims. So the existing evidence show that there is a current gap in terms of advanced care planning completion for ethnic minorities. Now, most of these data comes from the US. Unfortunately, we don't have our Canadian data, which would be interesting because we're dealing with different health system. But you can see from the US, the ethnic minority, the 18% completed advanced care planning compared to the majority white European ethnicity. And the same results seems to be consistent across different settings. Now, in addition to the ethnicity, which seems to be an independent factor for completing advanced care planning, there are also other factors that may affect the engagement in minorities group. Socio-demographic status, age and gender, income, education, health status and previous experiences, cultural values, and spirituality. I'm going to focus a little bit about spirituality just because we're talking about Muslim patient and spirituality is the focus of the discussion. So when we look at the evidence, religiosity, by the way, is different from the religious affiliation. So we were talking about Muslim not practicing Islam. Religiosity tends to measure the involvement of the person in the prayer, in the group practice, and their commitment to the faith. So it tends to be more accurate. So religiosity tends to be negatively associated with advanced care planning completion. Patient and participant with high religious coping, they tend to have high aggressive end-of-life intervention, high ICU deaths, and less likely to receive palliative care. Now, the data exists, tends to look at religiosity in general. However, researchers who did the studies, they kind of acknowledge that there are some differences in terms of beliefs and values between the different religions and different faiths. And they comment about that these differences sometimes may contribute. Unfortunately, we don't have any studies or evidence to link Muslim religiosity to end-of-life practices. Now, what makes religion, what makes people with high religiosity score less engaged in advanced care planning? Is it too much hope? Well, religion means to be about hope. It gives us meaning for suffering. It gives us the value. It connects us with other people. And it tends to be a source of hope for a lot of people. We heard a lot of stories where religion come to be the source of hope for the person with advanced disease. So is it too much hope that people now totally reliant on God, they're quite passive, and they're not quite willing to make any decisions because they feel that God is taking care of that, and we just need to hope for a miracle? Could be. Fatalism could be an answer for that. In the Islam, you'll find a lot of hope comes into the scripture. So this is, for example, hadith of Prophet Muhammad, peace be upon him, where he said, yes, you should seek medical treatment because God, the Exalted, has let no disease exist without providing for its cure, except for an alignment, namely old age. So again, sometimes people might take these hadith out of context and then start applying that to their illnesses. Or could it be, well, if you're sitting with a Muslim group, inshallah is the most common used word. Every time we say something, we say, oh, we'll do this, inshallah. We'll do this, inshallah. Inshallah, it means God willing. And it also implies that there is a total submission for God. So listen, we can't really do anything. It's always about God's will. And you can see that this also implies passivity, that we're letting God take charge. Or could it be fear? So death and anxiety, we know that it's prevalent. It's common in people with advanced illness. 50 to 20% of patients with advanced cancer, they have death and anxiety and death terror. Now, in Muslims, there is 3 different levels of fear that people encounter. The fear of losing the loved one. And there is also the fear of suffering or dying. There is the name for that in Islam is called Sakarat al-Maut. So people are afraid of the death and dying and suffering during death. There is also the fear of unknown after death. You heard about the beginning of a new life, but the new life starts in the grave. And a lot of times the grave can provoke different emotions, because grave can be, for Muslims, can be a hole in hell, or it could be a paradise in heaven. So it depends. You never know. And it depends on how good Muslim you are. You will start getting the reward that you deserve in grave. There is a lot of scripture that talks about the first night in grave and how an angel will come and ask you about your questions. And in able to answer these questions correctly, you have to be a good person. So it's not about knowing, but it's about your good deed. So there is this uncertainty, which sometimes can, I'm saying we don't know for sure if this is contributing to the religiosity low score, but we're discussing different patterns that may contribute. I think at the end we need more research. We need to talk to the people to understand why is it they are less engaged in the advanced care planning process. Now, I have only very limited time, so I'm going to try to go over some of the cases. Now, I have the advantage of being the coordinator here, so I can cancel the other presentation. Ahmed, you can take... So, meet Farah, who's 80-year-old female from Muslim from Africa. I met her in the palliative care clinic, in my clinic, and she has no children. Her husband was 85 or something, and they were dependent on their nephews and nieces who were really providing the care they needed. Now, part of my assessment is to start a discussion about advanced care planning. And I noticed that every time we introduce the topic, I get no answers. So what do you hope to get? What do you hope to do? I don't usually get answers. And then I kept seeing her like every 2 to 3 months just to follow up 1 to 2 months. And I'm not getting any responses. So what's happening here? If we look at evidence, we look at barriers that affect Muslims, we don't find really a lot of evidence. There is some studies that look into ethnicities, South Asian ethnicities, and there are some community focus group that was done in different countries, in UK, looking at the Muslim perception of advanced care planning. However, I think if we are to reflect further on this, communication seems to be a major issue. We have a lot of issues with language barriers. The use of the word make difference. So people coming from different cultures, talking about death is not something that people prefer. The use of certain words like death or cancer is avoided. Advanced care planning is considered to be a foreign concept. To a lot of people, they don't know what's that. Why should I plan in the future? It's good to plan for wealth, but not for my health. There is also no literal translation for the phrase advanced care planning in different languages. So it doesn't come very natural. So when you start explaining the concept, people do not really understand. Some of the changes that sometimes I find is that communication with the opposite sex, I'm a man, so sometimes when I'm talking to a Muslim woman, it may be compromised. They may not really feel comfortable enough to share their stories about their families. There is also the anthropological concept that talks about the different context of communication. So there is a low context communication which tends to focus on direct words, and there is the high context communication which tends to focus on indirect information and internalization. I borrowed this slide from the business psychology just to show the group why sometimes we have differences in terms of communication, and why this is such an important group important thing when we discuss advanced care planning. The other important factors that come to play is the family role. So we're dealing here, instead of the focus on individualism, it's more of a collective process. And a lot of times you need to reach some form of consensus within the family in order to achieve a decision. And some of the patients, they may be happy letting their autonomy go and allowing their family to take the decision. There is also a lot of dynamics within the family. So there is the power differential. So a lot of times there is the eldest son who's making the decision, and there are other family who may disagree with that. Now, family also does not operate in vacuum. There is a lot of social pressure also in the family. So from the community as well, the family get judged for what type of care they provide for their loved ones. So it tends to be very complex thing. So a lot of times when I'm dealing with family, I try to, from the beginning, try to verify with the patient what is the preferred communication style. Would you like me to talk to you, or would you like me to talk to your family? How would you like to receive this information? So we lay the ground from the beginning. This is the rules. So tell me, what type of person, Who would you like to make decision in this case? What type of information would you like to get? What type of information don't want to get? And I found this sometimes helpful. Now, the other important factor that comes in the focus group is the limited awareness. There isn't really any awareness about the importance of advanced care planning, end-of-life care within the Muslim community in general. I borrowed this quote from a focus group, and you can see from the group that there isn't really any form of understanding, which makes it difficult to engage since you don't know the value of that. My next patient is 45-year-old who has metastatic cancer, and she is a refugee from Asia. I saw her urgently for uncontrolled symptoms. So I ended up admitting her to the palliative care unit to take care of her symptoms. Now, despite the suffering she was in, she was very antagonistic to any treatment. We were talking about palliative treatment that may help with the symptoms, but she was very clear that she does not want any treatment. And she was clear about, I don't want anything that will prolong my life. Now, the fact that she was struggling, but she wasn't really accepting the treatment, and the fact that we explained many times that this is not something that's going to prolong your life, it's mainly just to help you with your symptoms. It made the group start thinking, are we talking about MAID request here, implicit MAID request? Is this patient interested in MAID, and this is why she's refusing or declining these things? And she kept saying that her wish to end, for her life to end soon. So I went there to speak to her, and because I'm coming from a Muslim background, when I asked her, how do you feel and how is everything, and we started the discussion, I realized that this patient is actually very religious. And what she is focused about is the fact that we're right now in Ramadan. And Ramadan, if you know me, Ramadan, usually we Muslims fast during daytime, so they don't eat anything, and nighttime, usually they do more prayer. So it tends to be a very spiritual month. And a lot of times, Muslims perceive Ramadan as the month of forgiveness. So God forgive people. And if you die in this time, then this is a sign of good death. So she was quite fixated that I don't want any treatment because I want to die in Ramadan. It's Ramadan and I don't want to miss this opportunity. If I can't die now, then this is why I don't want the radiation. I don't want the treatment. I want to die during this month. Now, some other patients also talked to me about their wish to go to Mecca or to the holy cities, where I had a patient who wanted to do her Umrah or visit to Mecca, although it was very risky because she's going to die within the few weeks. And in her mind, it doesn't matter. If I die there, that's a good death to me because I will be in the place where I want to be, and this will consider to be very spiritual and very happy ending for me. And we keep talking about like how this is difficult. She may have pain, she may have and she was quite insistent. She went to apply for visa, but then she had seizure and ended up being admitted to the palliative care unit and died. But the point here is some of the patients, they may not be willing to share their faith, belief, or with the medical team, because first of all, they don't want to burden the team, and sometimes they feel that they may be judged. Because if I tell someone about Ramadan, he may not really understand me. So sometimes it's always helpful to have the connection from someone with spiritual experience, with spiritual understanding, and then from the family. And keeping this communication can be quite helpful because this patient was willing to share it with me, knowing that I will know what is Ramadan. But she wasn't really willing to share it with the group because she felt that the group will not really appreciate her feeling. Okay, so so last thing quickly that I'm going to mention is the notion of confidence and trust in healthcare. So we have a lot of conflict. And it seems like part of the problems and part of why we have the barrier to completing advanced care planning is the notion of confidence and trust in healthcare. So we have a lot of Muslim patients or people from the Muslim community, they feel that there is an issue with the healthcare decision. They feel that this is not something that they can't trust. Now, Dr. Badila did an interesting study looking into in the American healthcare system about Muslims and what do they trust. And it was interesting to me to read that there is some trust in medicine, but this trust still can be affected by different things. It can be affected by their previous health or communal experience. And this is where the latest hate incident, and this is how the perception of Islamophobia can come into play, because the communal experience can reflect as a lack of confidence and trust in the system, and then can lead to this conflict. And the other interesting part is that people tend to trust different things. So I trust my physician, I trust God, I trust myself, and I trust my community, my personal friends. But sometimes these trusts can compete. So for example, I trust my physician, but then my friend is saying that there are some other treatment that we can try. I have more trust in my friend compared to my physician. Or I feel like I trust God more, so I'm going to take God well compared to the physician. And this is where we have this conflict. I think that this is an area that needs significant exploration. We need really to work very hard on it, and it takes a lot of work. And I think a lot of the cases that we discussed today, from Rasuli case to the different case, I think it reflects somehow an element of mistrust in the system. This is a quote that, again, I get from one of the notes. The last thing is advanced care planning has its own root in the Islamic faith, so it's not coming from nowhere. This is a hadith from Prophet Muhammad. It said, it's not permissible for any Muslim who has something to will to stay for 2 nights without having his last will and testament written and kept ready with him. So although this will, it talks about action after the person's death, it will still lay the ground for advanced care planning. We talk about advanced care planning as a Western concept, but we still can find a lot of things in the Muslim religion, in the Islamic religion, that relate to this notion of preparation and planning. And I think Amana's statement on advanced care planning tend to support that. What's the solution? Better communication, first of all. So we need to engage technology. So there is studies that show that using videos tends to be much helpful and powerful in discussing advanced care planning, for example, especially when we're discussing with ethnic minority where the euphemism might not be clear or the words might not be clear. There is a responsibility for the community. We need to improve the public awareness of the importance of end-of-life care and the advanced care planning. Healthcare practitioners need to know better about religious belief and values. We need to engage the community and religious leader. Campaigns are needed in order to improve the awareness, and we need to build trusting bridges, try to eliminate systemic racism and discrimination, and we need more research to understand how can we help people and deconstruct some of the myths about advanced care planning and end-of-life care. Final quote, the hospice and palliative care philosophy program are not about dying like Westerner or dying like American. It's about the human condition of dying and not wanting to die alone, in pain, unforgiven, without dignity or respect. Thank you.